Every leader has a strategy. Executing on that strategy is the challenge. If you want to learn how to effectively achieve what you've set out to accomplish, then this show is for you. Gain keen insights and listen in as leaders share their stories and challenges. SOAR Vision Group and the Baldrige Foundation welcome you to Leader Dialogue Radio.
Hello, everyone. I'm Duffie Dixon. Welcome to Leader Dialogue, brought to you by SOAR Vision Group and the Baldrige Foundation. Joining me is Ben Sawyer, the Chief Executive Officer of SOAR Vision Group. Ben has more than 30 years of executive leadership experience. He launched SOAR to help align people with purpose and to achieve exceptional results. Also joining us is Lisa Counsell. She is the Chief Commercial Officer. She comes to SOAR with more than 2 decades of clinical leadership and clinical informatics experience. She spent 19 years prior to this at the McKesson Corporation. We have a very special guest with us today. It is Dr. David Gifford. He is the Senior Vice President, Quality and Regulatory Affairs with the American Healthcare Association. And Ben, tell us a little bit more about Dr. Gifford. He has quite the resume.
Yeah, so Dr. Gifford, we're so delighted to have you on. For listeners, Dr. Gifford is a primary care physician and gerontologist, got his medical education at Case Western Reserve, and then finished his primary care residency and geriatric residency at UCLA. He was also a Robert Wood Johnson Clinical Scholar and received his master's in public health in epidemiology from UCLA at that time. Prior to coming to the American Healthcare Association, he was the director of the Rhode Island Department of Health and has had many prestigious appointments within the state and federal level, and is also quite fluent with health information technology. So, and one last thing is he is on the board of directors of the Baldrige Foundation.
Oh, okay.
As if that other stuff wasn't enough.
Right,
David.
exactly.
So, David, welcome. It's just a pleasure to have you on the show today.
Thank you. I'm looking forward to it.
David, can you tell us, with the American Healthcare Association, Ben had some pretty amazing numbers as far as how many organizations you oversee. We're talking about care for older citizens. How many facilities does that cover?
So we represent close to about 14,000 facilities across the country, about 10,000 of the 15,000 nursing centers, and about 4,000 or 5,000 of the 20,000 assisted living in the country.
Wow.
And that represents, just for the listeners, how many Americans that are being treated in those facilities on an annual basis, do you think?
Oh, well over 1 million people on any given day, and probably close to 3 or 4 million throughout the course of the year who are, coming and getting rehab and then going home or staying there because they can't make it home.
Yeah. David, let's kick this off for the listeners by helping them understand what the American Healthcare Association is and your role within that. And when you get in your role, if you don't mind sharing with them your alliance with the Baldrige Performance Excellence Program and how you adjudicate that yourself within the association, I think that would be really interesting for the viewers.
Yeah, so we're in one sense a very traditional Washington-based trade association representing members before Congress and federal agencies, but and then doing various things. But we also about 10 years ago started up a effort to really assist our members in improving quality, and one of the cornerstones of that is that we are run and administer a Baldrige program. So we're actually one of the affiliated programs. Just like there are many state-based programs, there are some what are called affiliated programs, and we are probably the largest affiliated program. We have about 1,200 to 1,300 applications to our Baldrige program a year, and we use the same Baldrige criteria and use the same national Baldrige examiners to help review all our applicants and award recipients.
And as I understand it, you have a 3-tiered program, bronze, silver, gold. Is that correct?
Yeah, as many states do. We have a 3, try to get people in because, to get to the highest level, it's a lot of work and it takes some time and it can be discouraging. And so we've sort of broken it into sort of a more stepwise process, bronze sort of introductory level, which is a subset of the criteria, silver, which is a full criteria but not having to achieve the same level of implementation and complexity, and then the gold level is the equivalent, and that's the same as winning a state award. And actually makes them eligible to apply for the national award. And 2 years ago, we had a facility out in Idaho receive the national award for this as well.
Right, that was
beat out all the hospitals.
I think that was Kindred Health, right?
Yeah, Kindred Health in Kellogg, Idaho. It's
so
wonderful to see. And people often think we don't have the same resources or requires the resources that hospitals or large organizations can do this. But I think the Baldrige framework not only is applicable in all healthcare settings and non-healthcare settings, but smaller organizations can do it just as well as a large organization.
Right. So for the listeners, David, we encourage them to follow along on our Leader Dialogue website. So it's www.leaderdialogue. Dialogue is spelled DIALOGUE.com. And on the homepage, they will find the organizational hierarchy of needs, which is essentially a representation or a visualization of the Baldrige. So it's a little bit easier to understand. And in the Baldrige Performance Excellence Framework, there are 7 categories. The first one is leadership, the second one is strategy, the third one is customers, the fourth one is what's called measurement, analysis, and knowledge management. We refer to it as MACM for short. And then category 5 is workforce, category 6 is operations, and category 7 is the biggest part of the representation of scoring. I think it's about 45% of the total score, and that is results. It crosses all the other categories. And the interesting thing about the Baldrige, as you alluded to, David, is it is very comprehensive and requires integrated top performance across everything you do, not just isolated areas of performance, correct?
Absolutely. I think one of the things that we've found amongst our members who are pursuing the program, that what distinguishes those who receive the award, and I think being on the Baldrige board and seeing the national recipients in all sectors, what tends to distinguish those who receive it from those who don't is that the applicants actually, it's their mindset.
Right.
Those who are pursuing this to win the award tend not to get it because it's about really implementing changes deep in the organization and not doing something for some outside recognition.
Right.
It's about being a better organization. And then I'd say similarly, it's understanding the intent and purpose behind each of those categories and then really making sure they are baked into your organizational structure in a way that helps achieve your mission. And so you often hear about people who are mission-driven. I often can talk to individuals and ask them what they think of the organization they work for, how they're doing, and after talking to them, you can sort of get a sense what their mission is. And when it matches what's on paper, you know you have a good organization. When it doesn't match what's on paper, then you know you have some discourse. Often reflected by, if I talk to staff and I hear the third-person plural of they or them when talking to sort of the workforce in an organization, you recognize that clearly they're not on this Baldrige journey because of the disconnect between management and the workforce. And in these Baldrige organizations, you just hear we and us over and over again. And I think those are the things that really distinguish the top performers. I mean, everyone is doing the same type of, strategic planning, the same type of sort of measurement, trying to bring the latest technology in. But I think it's that mindset that really distinguishes those who are able to do that in a way that achieves the mission and better outcomes for the populations they care for.
It's really interesting. We've talked on previous radio shows about the work of John Cotter out of Harvard, and he's done some really interesting assessment of what you're just talking about. And in one of his books, and based on his research, he talked about how only 5% of employees on average across companies understand how their job connects to the organization strategy, which is a scary number. And then he did a really interesting little study to try to assess middle management's engagement. So what he did is he took 6 strategic planning documents of companies and redacted the names, put them in a conference room, and then invited middle managers that worked for those companies to come in and find their company's strategic plan. That's all they had to do is just find it. And only 29% of them could find it, which advises you of the disconnect. So for the listeners, what Dr. Gifford is talking about is huge. It is gigantic to be able to get to we and us, and everyone is connected with the why, the statement of purpose, and aligned on mission, vision, values, and everybody's hitting it on all cylinders. It is a big undertaking and very, very powerful when it occurs.
Yeah, I'm sure many of the listeners have heard the story of, when Kennedy visited the Space Center and they're trying to put a man on the moon and ran into a janitor there, with a broom and cleaning up, and asked him what he does there, and he says, "I'm helping put a man on the moon."
Yes,
I think we were interviewing for an administrative assistant at American Healthcare Association a couple of years ago, and one of the applicants came in, and we asked her why she wanted to work here, and she said, "Well, I quit my job about a year ago and decided to take care of my dad at home who had dementia, and really wanted, to take care of him because we didn't want to put him in a nursing home out there, and the family rallied around that. And he died a couple months ago, and I want to come and work for you guys because I want to figure out how to make nursing homes better."
Wow.
I was like, "You're hired on the spot."
Exactly.
It was just, and she has turned out to be an incredible administrative assistant and really gets it and really understands the role. And so I think having a workforce like that in an organization, and in a Baldrige organization, you get the workforce like that.
Right, and from a leadership standpoint, which is category one, the challenge or opportunity is to help facilitate that kind of empowerment, right?
Right. So often everyone talks about leadership, but I think distinguishing characteristic is, people tend to get promoted into leadership positions because they can solve problems and they do a great job solving the problems. But by the time you get into leadership, you're not expected to solve the problems yourself. You're expected to figure out how to get your team and the people who work for you to solve the problems and how to coordinate that. And that's a different skill set. And often we don't recognize that transition of that skill set and provide the right training and education as people move up in management and leadership to get there. And those who keep trying to solve it themselves, you just burn out. You can't do it.
Mm-hmm. Yeah, so for the listeners, if you're on the homepage and you're looking at that organizational hierarchy of needs, the leadership effectiveness and essentially persistent curiosity permeates all of that organizational hierarchy of needs. And you'll notice, listeners, in the foundation of the organizational hierarchy of need is workforce engagement. So what Dr. Gifford is talking about is those two are significantly related. And essentially what happens is leaders are articulating the mission, vision, values, but they recognize that while they have authority in their position, they share responsibility with the front line. And basically operations, to a large extent, is a daily experiment. Like, how's it going? What do we need to change? And so forth. And unless there's a really good synergy there between the leadership and the front line, it's not particularly effective.
Yeah, I think one of the canary in the coal mine metrics for any business, whether it's healthcare or not, is your employee turnover rate and retention rate. Right. You want a little bit, and certainly, going to Collins and everyone else, you want the right people on the bus and the wrong people off the bus. So,
right.
You want to make sure you're dealing with that. But certainly, if you're having consistent and turnover, you need to look towards the leadership because it's setting the tone and culture that's driving people away.
Dr. Gifford, you're the first person I believe that we've had on to talk about geriatrics and post-acute care and long-term care in nursing homes. And that leads me to ask you, in this arena, what are some of the things that are unique? As you're talking about employee turnover rate, it's a tough job. Being in a nursing home, you have turnover of patients, number one. Number two, it's just, as in anything with healthcare, it is a 24/7. It can be very disappointing. You're dealing with family members at their worst. They're just what is unique about nursing homes and care for the elderly that you face? Some of your top priorities or some of your top problems?
Well, I think one of the challenges you articulated that is that you have individuals who are very difficult to care for, and it can be exhausting family members have tried as much as they can to usually keep people at home as long as they can, but there's no one can do that 24/7 at home, and that's why in the skilled facility they work in shifts, because you need to have breaks out there, and you need to have the right sort of support for that. I think the biggest challenge we face is sort of the complexity of the individuals there, balanced against the time and resources and expectations. Many individuals have spent all their assets down at home, and often one reason they leave their home to go is they don't have any assets to have the care at home, and so then they rely on Medicaid in the state. About 2/3 of everyone in a facility is on Medicaid because it's expensive to care for people at home or in a facility. Mm-hmm. And in many states, that Medicaid rates are inadequate to cover the staffing and full resources. So people try the best they can, and they really struggle. And there's a fair amount of literature. David Gifford from Harvard has shown that relationship with staffing and quality is really tied to the state Medicaid rates. But no one ever really wants to talk about that aspect of it. And then I think the other frustration is that we're a very regulated industry, because when bad things happen in this country, we tend to want to write more regulations for it. And those regulations sometimes actually have the unintended effect of getting in the way of what's out there. You definitely need them out there, and there are definitely some bad actors out there, as in every sector, but you want to figure out how to balance those all together. I think those are some of the bigger challenges. And then generally family members feel terrible that they've put their family members in a facility. Yeah. And so when bad things go wrong, they look to take it out on someone. I'll tell you, the aides I've worked with in the facility, when I was in practice with a medical director, and the aides I meet today, they're just saints. I mean, they care really for these individuals like they're family members. You've heard some horrifically terrible stories, I'm sure, during some of these disasters of things that happen in facilities. But what's not told is the countless thousands of positive stories where aides and nurses have left their families and moved into the facility to care for the elderly and helped them evacuate and traveled with them to other buildings, brought their families into the facility so that they could live there, and the whole family cares for everyone in the sense of these emergencies. It's really heartwarming to see, and it's the type of individuals I want to take care of myself or my parents when they age and need the services.
Yeah, so I can provide a personal story in that regard. My dad just passed away in September at age 91, and he had progressive Alzheimer's over the last 3 years. Yeah, and so he was being taken care of at a rest home up in the western Michigan area. It's called Rest Haven Homes. And as his mental capacity was diminishing, the one area of security he had was my mother, who was also 91 but medically frail. And because of their different care needs, she should have been in another part of the building, but because of their concern for him, they kept them together. But they had to put an ankle bracelet on him because he was a flight risk because of his Alzheimer's and stuff like that. And the level of care they provided was amazing. So I just echo exactly what you just said as a family experience there, David. By the way, I was going to go back to another point that you made. You said most residents in nursing homes, 2/3 of them are on Medicaid. How does that compare to the statistics of the close to 10,000 extended care facilities, nursing homes that you're talking about? How many is it equivalent? In other words, 2/3 of those also accept Medicaid, or is it some smaller percentage?
No, about 95% or more of all nursing facilities in the country accept Medicaid and Medicare. And there's a lot of confusion out there between that. Medicaid will pay for long-stay services in a facility. Medicare does not. What Medicare pays for is short-term rehabilitation after you've been in a hospital for 3 days. Right. And so the average stay is about 3 to 4 weeks. And many of those individuals, about 2/3 of those, go back home. So someone falls and breaks their hip at home, they've had a stroke, they go to the hospital because they had pneumonia, they get a little deconditioned. Many of them will go to a skilled nursing rehab facility for, a couple of weeks, get physical therapy, make sure the treatments get aligned, educate the family, and then they send them home. That's about 4 million people a year going through nursing homes across the country. But usually that's about 20, most nursing homes are about 100 beds, so about 20 of those beds are devoted to that. The other 80 beds are, the longer stay, often people with dementia, like you described with your dad and parents, and those are covered under Medicaid. And so by far and away, almost all the care is covered between Medicare and Medicaid. Clearly in the transition period, people often have to pay down their assets till they qualify for Medicaid, and it's a sad thing to see.
Right. It's very it's already tough on families, and then it's further disruptive when you essentially are compromising their financial stability. So another question I wanted to circle back on, based upon that research that you were talking about from David Gifford, what he was referring to is the connection between health and Medicaid rates, right, and the ability to support the elderly. Can you just elaborate on that a little bit? And I'm sure we'll have some follow-up questions, but I think that's an interesting point for the listeners.
Well, I think anyone understands that if you don't have adequate resources, enough staff and enough equipment and everything else to provide the care, you're going to struggle.
Right.
And what we've seen is the acuity and complexity of individuals has increased in nursing facilities across the country. But at the same time, most of them being reimbursed by the state Medicaid programs, which, every state's budget is under fiscal challenges, so they've often constrained that, and so there's a mismatch there. Now, that said, and I think just to tie it back to the Baldrige, even if you have adequate resources, doesn't guarantee that you're going to have great outcomes. And,
right.
We've seen that, and I think one of the distinguishing characteristics we see with the members who are pursuing this Baldrige framework, they outperform, and they actually tend to end up doing financially better because they tend to be more efficient. They have less turnover. There's a cost to that. They figure out better ways to provide care that's meaningful and effective, and get rid of the care that's not as meaningful and not effective. And so even in some states where their Medicaid rates are very, very low and often inadequate, those who pursue this journey do better and can figure out how to do it. So I think it's not always a one-to-one either way, but this is why we really are championing within our organization, Baldrige framework amongst members to adopt it, because we think it's a path to work through all these systems out there. That said, you still need the adequate resources. You can't totally compensate for that, and I think that's the work that Dr. Grabowski has shown, that as a broad policy, you need to make sure you adequately fund the care for the elderly in this country.
Right, and so let's bring this up a level to the overall healthcare dialogue that listeners are hearing about on the news all the time, which is increasing costs year over year, the need to drive those costs down, moving to value-based risk plans, etc. So does that same principle apply, Dr. Gifford, that what you've experienced in the post-acute extended care environment, by focusing on quality and focusing on quality and thereby driving efficiency and better financial performance, actually, if applied universally across all healthcare delivery, can have a similar effect?
Absolutely. The payment models and systems out there right now just don't make sense and are not helpful, I think, for the elderly, whether they're in long-term care or in the community or not. It's very fragmented. The payment doesn't drive coordination between healthcare providers, and it doesn't always incentivize better quality. It just incentivizes doing more. And while many people think more in healthcare is better, one thing I've seen amongst my patients, particularly elderly who are very frail and have a lot of complications, more is not always better.
Right.
More medication tends to make them more confused. Going to the hospital, which is very costly. People think, if they're sick, they should go to the hospital. We're finding out that that's really contributing to a lot of problems out there. So these payment models that tend to align preventing people from going to the hospital and meeting the individual needs do much better. And we've been very supportive of the shift towards that, but it just has been slow in coming. I'll give you one quick example. As I said before, Medicaid pays for long stay care, Medicare pays for short stay, you would think that states in the Medicaid would care about rehospitalizations and trying to pay and prevent them in the Medicaid program. But if a resident who's under Medicaid goes to the hospital, while they're in the hospital, Medicaid doesn't have to pay the nursing home. Medicare pays for the hospital stay. When they come back to the nursing facility, Medicare pays for a couple of weeks there. And so it actually saves the state money to have people go to the hospital.
Oh.
So you don't see any, it's not that it's a conscious decision, but there's no incentive for the state to develop a program in Medicaid to prevent people from going to the hospital because there's no financial savings. So a lot of issues are always driven around savings. So the problem is the savings of going to the hospital are accrued by lowering Medicare costs, but Medicare isn't paying for the long stay, so they don't have any say over it. So you've got this complete disconnect, which just doesn't make sense.
Right. So, Lisa, you've been a nurse for a long time.
Thanks, Ben.
And I'm
you didn't
sure
say long time at least.
Yeah,
Right.
and you've seen a lot of this. So weigh in on this as you're listening.
Well, I mean, clearly we want to keep people out of the hospital, and it's shocking to me that we haven't caught up in our reimbursement systems to really accommodate that. So, I mean, again, I just implore us as, consumers of healthcare and as our parents age that we really have to get involved from a legislative perspective, and we really have to help Dr. Gifford and others out there to really try to promote, this appropriate incentiveness for delivery of care and for payment. So, I mean, again, I was a critical care nurse, and the last place you want to be is in the hospital. So for us not to be paying accordingly and really trying to work on creative programs, which I loved, Dr. Gifford, you talking about how the Baldrige really does promote, organizations to think outside of the box.
I would love to talk about that more.
Yeah. In our deep dive, I definitely want to get into that.
I don't want the readers to feel like nothing's moving. I mean, I think things are moving in the right direction. We have a number of states that are in the Medicaid programs that are starting to link their payments to quality and rehospitalization rates for all the reasons you said, Lisa. And we actually have there are 3 states out there right now, Florida, Tennessee, and Utah, that actually link some of the Medicaid payments to nursing facilities, increases it for those who are pursuing the Baldrige framework and receiving the Baldrige recognition,
great.
because they know that's going to help the residents overall and lower costs. And so I think there are some innovative states pushing that out there, and it's great to see. We need more of it.
That's awesome.
So for the listeners, next week we will be doing our deep dive session, and Dr. Gifford will be joining us for that. And there are a number of topics that came up that we're going to want to tackle. One of them is innovation, which is what we were just closing with. So, how can organizations think outside the box and do things differently and more effectively? The second topic that was interesting that I think listeners will want to hear more about is the payment model collisions and the fact that it's not well coordinated. And then at the core, the quality focus, Dr. Gifford, that you talked about, and how organizations that focus on that and use the Baldrige framework can figure it out even in less resource-rich environments, how to provide better and more effective care. And then the fourth one was what we talked about with leadership, that it's not just about, you get promoted because you solve problems, but when you're a leader, you're actually
teaching others to
solve
problems.
others, which goes to the last item, number 5, which is the empowerment of the workforce. So those are a lot of topics to surface, but I think very, very relevant. If you agree, Dr. Gifford, from today's session, and maybe we can tackle those then in our next week's show. Does that sound reasonable?
Oh, I'd be excited to. That would be sounds like a lot of fun.
All right. Well, we'll see
Sounds
you
good.
in 1 week. And thank you to our listeners for joining us yet again on Leader Dialogue, brought to you by Sawyer Vision Group and the Baldrige Foundation. Remember, you can listen to a new live show every Friday at 1 o'clock Eastern Time. You can visit Business RadioX, click on Gwinnett Studio, and select Leader Dialogue. Or you can also go on to leaderdialogue.com/podcast. On behalf of Ben, Lisa, and our producer Mike, I'm Duffie Dixon. Join us next time on Leader Dialogue here on Business RadioX.